All right. So the next topic in part two is treatment for congenital long QT syndrome. Also, we studied QT prolongation in part 1. The causes were hypocalcemia, hypokalemia, hypomagnesemia. These are acquired causes. And also, as I was going through each question, I realized it is very important to memorize these acquired causes of QT prolongation, which is antibiotics like macrolides, fluoroquinolones, psychotropics, antipsychotics like TCA, SSRIs, opioids like methadone, oxydone, antiemetic like ondansetron, granisetron, antiarrhythmics like quinidine, procainamide, flecainide, amiodarone, sotalol. And inherited causes are Jervell-Lange-Nielsen syndrome, that's an autosomal recessive disorder, and Romanov-Ward syndrome, that's autosomal dominant disorder. So now coming to treatment of congenital long QT syndrome, the first thing is to avoid exacerbating factors, which are of course hypomagnesemia and hypokalemia, and also other QT prolonging medicines, which I just told. And treatment is beta blocker reduce the risk of syncope and death. Beta blockers reduce the risk of syncope and death in patients by dampening the sympathetic activity. So beta blockers reduce the risk of syncope and death by dampening the sympathetic activity and shortened QT interval. The benefit is more with non-selective beta blockers like propranolol and nadolol. So usually we use cardioselective beta blockers. In this case, non-selective beta blockers like propranolol and nadolol are more useful. Treatment for high-risk people with QT prolongation is cardio defibrillator placement or left cardiac sympathetic denervation. Cardio defibrillator placement and left cardiac sympathetic denervation. One important key point here is that we just studied that sotalol is a acquired cause of QT prolongation. So despite the beta blocking properties of sotalol, it is avoided because they inhibit the potassium channels. So the sotalol is not used. So the next topic is aortic stenosis. 3 important key features of aortic stenosis is diminished and delayed carotid pulses, mid to late peaking crescendo decrescendo systolic murmur with maximal intensity at second intercostal space, soft and single S2 inspiration. So diminished and delayed carotid pulses, mid to late peaking crescendo decrescendo systolic murmur, and which has a maximal intensity at second intercostal space, soft and single S2 inspiration. So why diminished and delayed carotid pulses is because there is a severe valvular left ventricular obstruction in the left ventricular outflow, reducing pulse pressure, weakening systemic pulsation. So sometimes you can, not sometimes, most of the times it radiates to the carotid pulses as well. And mid to late peaking crescendo decrescendo systolic murmur, you can feel that in the carotid region as well. And as I told, the key feature is mid to late, but you can also appreciate early peaking systolic murmur in mild to moderate cases, not in severe cases. So if it is severe case, it's mid to late. If it is mild to moderate, you hear a early systolic crescendo decrescendo murmur. And what about the soft and single S2 inspiration? So usually the aortic valve closes first, that is called A2, and the pulmonic valve closes second, which is called P2. But in this case, as there is a stenosis, both becomes one, and there is a soft and single S2. Not just this, this aortic stenosis also has a feature of a paradoxical splitting. That is, during inspiration, the aortic stenosis, the aortic valve closure almost is at the same time of pulmonic valve closure. So there is one single soft S2, but during expiration, the aortic valve closure delays further and it even occurs after P2. So this is called paradoxical splitting. Normal physiology, A2 occurs first and P2 occurs next. Other conditions you can see paradoxical splitting is aortic stenosis is the most common case where you see the paradoxical splitting, but you can see paradoxical splitting in left bundle branch block, severe LV dysfunction, and hypertrophic cardiomyopathy. And speaking about this splitting A2 and P2, there is one called wide splitting. A2 and P2 are further apart than normal. So these are, and this wide splitting is during both inspiration and expiration. That is, these can be seen in right bundle branch block, pulmonic stenosis, any condition delaying right ventricle emptying. Any condition delaying right ventricle emptying. And the another type of splitting is fixed splitting. S2 split is same on inspiration and expiration. So this is classic in atrial septal defect. This is classic in atrial septal defect. S2 split is same on inspiration and expiration. And isolated causes of aortic stenosis are, where is that? Yeah, due to age-related sclerotic changes seen in older patients, and you hear the maximal impulse at apex. I have written this down here also, and the ejection type systolic murmur. And what is ejection type systolic murmur? It occurs after S1 with a mild click or a short delay and ends before S2. So it occurs after S1 with a mild click, ends before S2. So I went down a little bit of a rabbit hole and was studying normal physiology of S1 and S2, especially A2 and P2 during inspiration and expiration. So what happens during inspiration on the right side of the heart is that with inspiration, the intrathoracic pressure becomes higher and the venous return to the right atrium is higher. So the right ventricle fills more, and the fuller RV takes longer to eject the blood. So that's why the P2 is delayed and A2 occurs first. What happens during inspiration in the left side of the heart is that pulmonary vessels expand. You see the intrathoracic pressure is decreasing, so the pulmonary vessels expand, temporarily traps blood in atrium, less blood to temporarily traps blood in atrium, less blood to left atrium, and left ventricle fills slightly less left ventricular preload, and A2 occurs earlier. So this is what happens during inspiration and inspiration of right and left side of the heart in regards to A2 and P2. But in expiration also, A2 occurs before P2, but slightly more closer. So what happens during expiration is intrathoracic pressure rises, venous return decrease, right ventricle ejects faster, P2 occurs a little bit earlier than A2. And what happens on the left side of the heart during expiration is that pulmonary veins fill more to left atrium, left ventricle fills slightly more, left ventricle ejection lasts slightly longer, A2 occurs slightly earlier. So only the gap differs, but in both inspiration and expiration, A2 occurs first and P2 occurs second. So in part 2.1, we studied the criteria for valve replacement in severe aortic stenosis. In that, we mentioned something called jet velocity and the valve area. So the normal jet velocity is lesser than 2.0 milliliter per second. And mild is 2.0 to 2.9, moderate is 3.0 to 3.9, and severe is more than 4. So it increases by the fold of 10, but the normal is lesser than 2.0. Same with normal and abnormal values of valve area. 3 to 4 centimeter square is the normal. Mild, moderate, severe, and critical decreases by 1.5. So 1.5 to 2 centimeter is mild, 1.0 to 1.5 centimeter is moderate, less than 1.0 is severe, and lesser than 0.7 is critical aortic stenosis. Severe is less than 1, critical is less than 0.7, and normal is 3 to 4 centimeter square. And the next topic is athlete's heart. This kind of looks like, this is in comparison to hypertrophic cardiomyopathy. So usually the athletes have sinus bradycardia, but they don't have atrial enlargement, only the left ventricle hypertrophy, in contrast to atrial enlargement in hypertrophic cardiomyopathy. And the cavity size is enlarged in the AV cavity, atrioventricular cavity size is enlarged in athlete's heart. In ECG, you see low-grade first-degree AV block or Mobitz type 1, and increased QRS voltage and J-point elevation. And T-wave inversion in V1 lead is most common in athlete's heart. T-wave inversion in V1 lead. So I just checked what is J-point elevation. It is the point where the QRS complex ends and the ST segment starts. Here the ST segment is bit above the baseline, isoelectric baseline. So that is called J-point elevation. And another thing you see is T-wave inversion in V1. And it's relatively common. And now the next one is kind of like points. Cardiovascular conditions for people who want to get pregnant. So cardiovascular contraindications to pregnancy: symptomatic mitral stenosis, symptomatic aortic stenosis, symptomatic heart failure with less than 30% ejection fraction, pulmonary arterial hypertension, bicuspid atrioventricular valve with ascending aorta enlargement more than 50 millimeter. Bicuspid AV valve. And the the normal hemodynamic changes during pregnancy is increase in blood volume up to 50%. This would make sense why those were all contraindication to pregnancy. Increase in blood volume by up to 50%, and increase in cardiac output of to 50% during second trimester. And mitral stenosis is the most common cause of pregnancy related cardiac complication. Aortic stenosis also has high risk, but it is less common than mitral stenosis. Now the next topic is, what does cardiovascular drugs do? So we studied this in part 1 as well. I'll just go over it again so I can remember it better. Beta blockers reduce the myocardial oxygen demand. Statins has anti-inflammatory effects. AC inhibitor, angiotensin 2 receptor blocker facilitate cardiac remodeling. Aldosterone antagonists like spironolactone, eplerenone is used because they increase sodium and water excretion, so lowers BP, reduce fluid overload, but they can cause hyperkalemia, and they reduce cardiac remodeling, which is helpful in heart failure. And where do we use this aldosterone antagonists? Is heart failure, resistant hypertension, primary hyperaldosteronism, and cirrhosis with ascites. All right, the next topic is acute mitral regurgitation. So what are the hemodynamic changes we see in mitral regurgitation, acute mitral regurgitation, compensated chronic mitral regurgitation, decompensated chronic mitral regurgitation. So the preload is highly increased in acute MR. What is preload? Preload is the volume the ventricle filled with at the end of at the beginning of diastole. So that is the preload. So why the preload is highly increased is, in the previous cycle, due to regurgitation, the ventricle would have pushed more blood into the atrium. So that, along with that blood, the left atrium receives from pulmonary vein is also added, thus increasing the preload in acute MR. It is very much highly increased in acute MR. In compensated chronic MR, it is increased, and in decompensated chronic MR as well, it is decreased because of two volumes of blood coming into the left ventricle. And the afterload is decreased. Why? Although the preload is high, the pressure the ventricle needs to push the blood out is low. Why? Because now the ventricle has two exits, one into the aorta and one into the atrium. So this has two exits, so the afterload is decreased. In compensated chronic mitral regurgitation, there is no change in the afterload because these guys have kind of compensated themselves. In decompensated chronic mitral regurgitation, the afterload is increased. In acute, it was actually decreased. Sorry, in acute, it was actually decreased. Yeah, the afterload is decreased. Why? Because there is little, there are two exits. But in decompensated chronic MR, the afterload is increased because the left ventricle dilates and it loses its contractility, thus increasing the afterload in decompensated chronic mitral regurgitation. In the contractile function, there is no change in acute MR, no change in compensated MR, but decrease in decompensated chronic MR, the decompensation. It cannot contract more. The ejection fraction is very highly increased, and compensated in compensated chronic MR, it is increased, and in decompensated chronic MR, it is decreased. I was wondering, if the blood is going into two exits, how come the ejection fraction is high? Apparently, the ejection fraction is calculated by as how much of blood is ejected out, not just into the aorta. It includes the blood into the blood which goes into the atrium as well. So hence the ejection fraction is very high in acute MR, high in compensated chronic MR, and decompensated chronic MR, it is low. And the forward stroke volume is decreased in acute MR. What is the forward stroke volume? Is the blood going into the aorta. That is decreased, and there is no change in forward stroke volume in compensated chronic MR. So no change means that these guys have compensated within themselves, and there is no change in forward stroke volume in compensated chronic MR. And in decompensated chronic MR, of course, it is decreased. And the type of murmur you hear in acute MR is a low-grade 2/6 holosystolic murmur because of blood flowing backward to atria and rapid equilibration of left ventricle, left atrium and left ventricle. And in chronic MR, the murmur is very loud. This is all about acute mitral regurgitation. Do I have more? Also, along with holosystolic murmur, you also hear bibasilar crackles in acute MR. So the left atrium has inadequate time to stretch all the blood. So although it remains normal in size, the left atrial pressure is transmitted backward into pulmonary circulation, which becomes pulmonary edema, which is heard as a bibasilar crackles on auscultation. All right, and I'm running out of energy. I don't think I'll be able to do more. So I may go take some rest or eat something and stopping this video in 20 minutes. So maybe this part 2 will become, or this part 2 is going to have more subparts because of this little videos. Anyway, I'll see you or see myself in the next video. That's all for now. Hope you all pass the exam. Peace.